Okay, over to you.
Great. So, hi everybody. So my name is Smit. So, yeah, I thought maybe just before we start the teaching that I maybe just give you a little bit of background to what I've done previously. So, this is a picture of where I worked in the UK. So I did my training in the United Kingdom, and I spent quite a lot of time at St George's Hospital. So this is one of the trauma centres in London. So I probably spent about 4 years there. It was a great time in the UK. And then I moved, this is a picture of us in Pietermaritzburg, and we were all very excited with this ultrasound machine that we managed to get because the things happen very slowly in KwaZulu-Natal. And these are one of my colleagues, Nick Dufour. And then I moved over to critical care in Gray's Hospital. Now you can see the difference between Gray's Hospital and St George's Hospital. There's about 50 shades of grey there in Gray's Hospital. And then subsequently I moved to George. So for you that don't know or not familiar with George, it's obviously in the Southern Cape. And here's a picture of what it looks like. So if we look out the windows, this is what we're dealing with. So this is the hospital over here. And we are quite a busy unit. So we see about 42,000 people, 42 to 45,000 people per year. So on the count, I think it's probably the third busiest EC in the whole of the Western Cape. And just as a quick what we end up dealing with here in George. So this is the view this morning, that on our ride this morning. And so this is some mornings what we deal with here at George. So it's tough life. It's a little bit different than the city life. And also one of the reasons, I came to George. So this is a view from the Garden Route Dam. So you can see the mountains there in the background. And so this is on top of George Peak. This is a vertical kilometer climb. And if you count carefully, there are 1, 2, 3, 4, 5 kids here, plus a wife. So these are my 5 kids. So so that's what we're dealing with here in George. So for you that want to come visit and do some things, George is the place to be. So just to kick off with our lecture, hocus or pocus in fluid management, and fortunately or unfortunately, I don't have any disclosures. If I had something to disclose, it would have been financial. So that's a pity, but I don't have any disclosures. So for you that's come and thought, maybe I'll be able to give you some silver bullet about fluid management and what it entails, and you can apply this to every patient and get to the answer. Unfortunately, you will be disappointed. There is no silver bullet in terms of fluid management, and it's something that we need to individualize with every single patient. So what we're trying to do with fluid management, so we hopefully are trying to increase the cardiac output and hopefully improve organ perfusion. And on the other side of the scale, we want to prevent tissue edema, prevent hypoxemia, and hopefully decrease mortality. And this is a very difficult balance. So if all of you are familiar, excuse me, familiar with this curve of where people are in terms of fluid management, and we hope that we find people on this side of the curve, and if we do give them an increase in their preload, that they will increase their stroke volume. And of course, people have systolic failure and so forth. And what we're trying to achieve is move people hopefully up on this curve and hopefully find them somewhere around about there. And that is actually quite difficult to do. So there on the market, there's a whole myriad of devices. There's the USCOM, there's the Vigileo, there's the Litco, there's a good old-fashioned Swan guns. We've got the esophageal Doppler, the Pico, the Litco. And, there's really no, there's enough of these machines on to keep you happy with numbers. And the last one I've got on here is the EV 1000 from Edwards. It can actually look and tell you what the extravascular lung water is also, and gives you a lot of numbers that you need to interpret and need to be able to figure out what to do with all the numbers. But is this all hocus? Or from an ultrasound point of view, you're saying what you can't do that with ultrasound. So surely we need these machines. And I'll maybe go through a few things that you can do just to help you. And those of you that are familiar with cardiac ultrasound, I do a lot of echo. So this is the apical 5-chamber view. So if you were to put your Doppler through the aortic outflow tract, you can actually measure the VTI, and that doesn't need particularly special equipment. Obviously, your ultrasound needs to be at a level that it's got the cardiac package to be able to do that. So once you do the VTI, if you've got a variability of about 12%, you're pretty sensitive and specific for fluid responsiveness. And if that's a little bit too difficult, you can even use just the peak of your VTI at the 5-chamber view to just look at that variability as the patient breathes. And more than a 12% difference in that is also quite specific and sensitive to predict if your patient's fluid responsive. So for those of you that have a bit of difficulty getting the 5-chamber view or not comfortable with using it, the carotid is always close by. And so some people have purported, using the carotid. And so if you put your VTI over the carotid, you can use that also and look for variability. So if there's more than 20% variability, your sensitivity and specificity, it's actually pretty good to predict fluid responsiveness. So that, I think no one can argue that they can't get to the carotid and put a Doppler over that. So just getting to the central venous pressure. So, there are a lot of numbers that are floating around. So, should we use the IVC? And if it's less than 2.1, what is the actual value, in the right atrium? And you can see on this chart, people have been trying to figure out, what do we do on the venous side? And hopefully that will give you an idea about the right atrial pressures. I think the problem is that we know that CVP, for those of you that know this article, this systematic review of and the Tale of 7 Mares that was published by Paul Marrick. And in that, basically it says that CVP is pretty useless at predicting fluid responsiveness. So, and I think all the measures that we are using at the moment, unfortunately, like IVC and so forth, and we'll go through some of them, sits on the venous side. So what does it actually help to know what the venous side is? So we're looking at a specific number on the venous side. And actually, from that point of view, actually makes it quite difficult to know how to interpret that in different patients. So it's one thing when you have a young patient versus an 80-year-old, someone with pulmonary hypertension. These things get very complicated, when you apply a single rule to your patients. So I don't know if any of you are familiar with this curve, but I think what this basically shows, so here's the Frank-Starling curve. So we are obviously trying to increase the preload and hopefully increase the cardiac output at this point. But this curve over here is the extravascular lung water. And at some point, and really for each patient, this is different, and we don't really know, when we are pushing the preload even further, even though we get a modest increase in the cardiac output, we get a huge increase in the extravascular lung water. And we got to figure out, is this really worthwhile, pushing the cardiac output or the stroke volume up to this point at the expense of that? And of course, we are sitting in the EC and we don't always see the effects of fluid and fluid management afterwards. So here's just a few articles that you can go through. So in a positive fluid balance, and of course, oftentimes the fluid that we give in EC isn't charted. Well, if it's anything like what and sometimes in our unit, is not charted always as accurately as you want it to be. So once they get to ICU, they oftentimes they're not sure how much resuscitation they still need, and then they get fluid and they get more fluid. So the Malbane is a gentleman that has done a lot of the work of intra-abdominal compartment syndrome, and he looked at there's definitely a worse mortality in critically ill patients if they've got a positive fluid balance. And the SOAP study showed increased kidney injury, and then also the FACT trial looked at the ARDS or acute lung injury, and definitely worse with a fluid balance. So the VAST trial was the worst mortality in septic shock, worst morbidity in colorectal surgery, and it's also associated with intra-abdominal hypertension, and we know all these things. So I think the question is, you know, how much can we give our patients? We certainly don't want them to drown, but where's that balance that we can get in terms of our fluid balance? And I think probably a better way to think about the fluid is fluid tolerance and not fluid responsiveness. And the question just really is, if I give this patient fluid, can they tolerate it? The next question is, do they actually need it? And this is actually very difficult. And I think this is where expertise comes in, and where you can't use a single measure to make that call. I think what we've seen in COVID, certainly, I think on our side, is that before you know it, your patients had too much fluid, and then once you got renal dysfunction, decreased urine output, you are trying to get rid of that fluid, and that is sometimes extremely difficult. So if you look at the venous system, I think what you've got to keep in mind is that the right side, the venous side, and the arterial side, and we actually got to look at both. We can't just use a single measurement to try and figure out what, you know, if we should give the patient fluid or what pathology is going on with the patient. So here, this is where point of care ultrasound comes in. And again, I think ultrasound's only so good, and the information you get out of it is the same as all these devices that we have. If you don't know what to do with it or how to interpret it or which of these to ignore, you know better. So I'm just going to go through a few things that I think might be helpful. And as I say, you can't use a single measurement for this. But I don't know if you've come across the VEXUS protocol. So this is probably might not be familiar to all you, because the work was actually done on cardiac surgery patients. But I think probably some of it will be useful for us. So this really looks at the venous side of the system, and as you can see here on step 1, you look at the IVC diameter, and if it's more than 2 centimeters, you can proceed to step 2, and then you go and you measure the hepatic vein Doppler, and there are usually 3 patterns that you can find, and this is what they look like. So this is normal, mildly abnormal, and then severely abnormal. So what you see in a hepatic vein is that you get reversal of flow, and you know, I think once you get to this point, you've definitely given too much fluid. So hopefully you won't be in this situation, you know, where you get a severely abnormal. So we need to actually stop before we get to any of these. So then you use the portal vein Doppler, and I'll show you some pictures of how to look at that. And then you look at the pulsatility index. So less than 30% is normal, 30 to 40 is abnormal, or mildly abnormal, and then severely abnormal is more than 50% pulsatility index. And then there's the renal vein Doppler that you can also use. So this is just a picture of the hepatic vein Doppler. So the hepatic vein, if you do your subxiphoid view and you look at your IVC, the hepatic vein comes into this area. So you put your Doppler over it, and this is the pattern that you get. So the portal vein you can access also from the epigastrium, and usually the portal vein is quite easy to spot because it's quite a big vein. And again, you put your Doppler over that, and what you do here is look at the variability. So as you would do for those of you that's familiar with TAPSE, you look at the change in this and look at the variability of that. So when it gets to the renal vein, I have to say I don't do this personally. I usually hope that I don't get that far, but you can look at the interlobar vessels in the kidney and then just look at the flow also, and again there's a pattern for that. So I just want to quickly go through the rush protocol, because I think a lot of you probably know about the rush protocol, and there are a lot of variations to this. I mean, EGLS has a certain way of doing it. So for me, I do the rush protocol, and I think some of you might have different protocols that you prefer. I think the good thing about this is you see your patient in totality, and you look for certain pathologies rather than just focusing on a single measurement maybe that you do with the ultrasound. So I'll quickly run through some of them. I've got some of the videos that are mostly from Edendale that we've got. So it's the rapid ultrasound in shock and hypotension. And the mnemonic that you use for this is HIMAP. So HI is for the heart, IVC, Morrison's pouch, aorta, and look for pneumothorax. So just quickly for the heart, so pericardial effusions and tamponade. So if you were just to look at the IVC and try to use it as a measurement without looking at the heart, I think you'd miss certain things. So you can have a really big IVC, but if you haven't looked and see the pericardial effusion, you would have interpreted that a different way. So this is a picture of a patient that we had, sorry, a video that we had at Edendale, and you can see it's a massive pericardial effusion. And you can also see the RA is particularly big. So this is just a measurement that we did. So that is 4.34. So that's a massive pericardial effusion. You can imagine that patient's hypotension, isn't that wouldn't be particularly helpful to give this patient a fluid bolus when you've already got so much congestion in the heart. So this is another picture of another patient from the apical four-chamber view. Oh, sorry. So from the apical four-chamber view, and you can see the heart bouncing around in this pericardial effusion. There's fiber and stranding also. This is just a subxiphoid view, and again you can see the large pericardial effusion. So these things are important to pick up, and I think we pick up so many things that you weren't expecting, and I think that's the beauty of ultrasound compared to having a machine that gives you a lot of numbers and without really knowing why the numbers are like it is. So just quickly into LV function, I mean, a lot of people that ultrasound with me, they're quite interested, what is the ejection fraction, is it diastolic dysfunction? But oftentimes we don't need that information to make a clinical call. If you just put the probe on and you just have an idea, most people will be able to figure out, what is going on with the ventricle. So this, for instance, is a patient that we had at Edendale. And again, if you look at the heart, the chambers are dilated. Here's the descending aorta. There are pleural effusions. And clearly, the contraction in this heart is not great. So again, if you put that in context with maybe IVC collapsibility index, or you look at your stroke volume and you see this heart, it's really going to change the way you think about the patient. So this is a patient with severe hypertrophy. As you can see, the LV, the posterior wall is very, very, very thick. And although if you look at the contractility, you might think, actually the contractility is probably not that bad. But when you see such severe hypertrophy, this person's got diastolic dysfunction. And of course, we can measure diastolic dysfunction, but I think this will definitely put a different perspective on the patient. So the RV, we focus a lot on the LV, but the RV is just as important. And I think the function and the size is really important to have an idea. So this is a patient that we saw in Edendale. And interestingly, this patient was sitting in orthopedics outpatients after having, I think it was a femur fracture. And the patient had a syncopal event there and was brought into the EC. So obviously, I think the diagnosis wasn't that difficult to figure out. But if you look at this RV and you look at the right atrium, it's massive, and that the RV is bigger than the LV. Again, in terms of what we do this patient, should we give them a fluid bolus or should we give them other treatment? I think that really does make a difference. So this is just another view of the same patient, and I think if some of you, it's not the best view, but you get an impression of that there's a D sign. So there's a flattening of the intraventricular septum, and then that's what we call the D sign. So this patient actually was thrombolized and did very well. So just another quick thing, if your ultrasound machines do have the capabilities, they're very easy to measure the pulmonary artery pressure. So if you get your TR and you put your continuous wave over that area, all you need to do is just get the regurg maximum, and it will work out your gradient there, which in this case would be 48. And what you need to do is just add your right atrial pressure to that. And generally, it's going to be either 3, 7, or 13, and you can take your pick. If the IVC is massive, the RA is massive, you can pick 13. If everything's small, it's going to be 3. So it's actually quite easy to figure out what the pulmonary artery pressure is. And again, for a patient that's got such a severe TR, you need to think, do I need to really give this patient a fluid bolus? So just quickly on the IVC and the size and the index, I think it's obviously we have been talking a lot about the collapsibility index. I think probably a better term for that is the caval index, and not name it the collapsibility index, because of course if the patient's intubated, then it's the distensibility index. So just to avoid confusion, if you just call it the caval index, that might decrease some of the confusion. So again, so this is a subxiphoid view looking at the IVC, which is usually easy to see in most patients. And then I'm sure you are familiar with putting an M mode over the IVC and then measuring the biggest diameter and the smallest diameter. And in this case, that would give you a collapsibility index of 16.7%. And this is just an example of an IVC that is collapsing. So it's 48%. So again, what to do with these numbers depends on the patient. You know, a lot of people ask me, you know, is it 50%? Is it 30%? And really, I don't think you can use a specific number in a patient. You need to know what is the pathology, what's the underlying condition, and then you make a call when you've looked at everything, rather than just focusing on one single index. So Morrison's pouch, of course you guys are well familiar with your ultrasound. So you know, if there is free fluid in the abdomen, that needs explanation. So is this trauma? Is this ectopic pregnancy? And you'll be surprised what you see sometimes. The interesting thing is, I did an ultrasound last week of a patient that was stabbed probably around the third intercostal space parasternally, and okay, the patient had a pericardial effusion, which was to be expected. But then I ultrasounded the rest of the patient, and he had free fluid, everywhere. So actually, what happened is that the stab wound must have nicked the heart, and the knife went all the way through into the diaphragm, and he was actually bleeding from his pericardium into his abdomen. So if he was to be hypotensive, and you literally only looked at the heart, you would have thought, oh, he must be tamponading, but actually he wasn't. It was just a fluid deplete because he was bleeding into his abdomen. So this is just the left upper quadrant. So I'm sure all of you have seen videos of this. And then also this is the the right upper quadrant, and you can see, and this is oftentimes things that we see, and I always have a look at the lung at this point, because the lung actually, this is what atelectasis looks like. You can see the lung, and of course, whenever you've got an infusion, there's always collapse around the lung. So then you've got an idea about what atelectasis looks like. So just in terms of the aorta, obviously, I think in the right patient, the right context, to have a look. I've been caught out a few times. I think also in Edendale, we had a patient that was about 35 years old that came in hypotensive, and actually the patient did have an aneurysm, and it was probably a syphilitic aneurysm. So, don't be caught out by thinking, oh, it can't be. And, with ultrasound, it only takes a few seconds to have a look and make a diagnosis. So pneumothorax, I think all of you are well familiar with looking at pleural sliding. So this is just a video of a patient that has pleural sliding, and you can see the comatose artifacts running down from the pleural line. And then, of course, M-mode. I don't particularly use M-mode. I usually just look, but this is a seashore sign. And then also just when you've got absent pleural sliding. And then, of course, you can use M-mode over that also. So just quick, I think, again, for this patient, this is what we call, so this is the liver on this side, and this is the lung. So it's quite a good ultrasound. The patient that we ultrasounded and weren't quite sure, is this a bit of heart failure, what exactly is going on? But if you look into these areas, you'll see that there's movement in there, and that's actually because there's still airflow in that, and it's a consolidated lung, so it actually looks like the liver. But the reason why you see this movement over here is that the bronchioles are still open, so there's not atelectasis, and there is small air bubbles that move up and down into the bronchioles. So this is consolidation. So this is pneumonia, and if you spot that, it makes a difference to what you do with your fluid balance, because this lung if you were to try and get this patient their cardiac index up, this lung is going to get edematous, and the ventilation is going to get worse. So this is one of these patients, actually, when they're hypotensive, we actually want to give minimal fluid and just start adrenaline straight off. So these are just B lines, and again, so that's a sign that we get with interstitial fluid, and that can be from pulmonary edema or pneumonia or any interstitial lung disease. So what does the future hold for us with ultrasound? I think going forward, there are so many devices these days. There's a V-scan, there's a Samsung device, there's iSono, and some of you might be familiar with the IQ, the Butterfly. And I think certainly in the future, we are going to be using ultrasound a lot more, and I'm sure most of you are using ultrasound. But ultrasound's only so good, if you're the person interpreting the data. So there's no point in having a lot of information that you don't know what to do with. So getting the images is one thing, but analyzing that data that you get from that with the right patient, I think that is where the trick comes in. So I think certainly going forward, I think all these devices that we have, in terms of the other devices that I've shown you, the time to measure cardiac output, I find ultrasound a lot more useful because I've got a better idea, a better understanding of the whole system, and I can also look at certain pathologies versus a machine that just gives me a lot of numbers that I don't know why the numbers are like that. So in summary, we looked at the ultrasound utility and volume assessment. I think the VEXUS protocol could be quite helpful. And I think a rush for me is quite useful to be able to look at my patient as a whole and not use a single measurement or a single assessment to make my call about fluids. So I think in general, my thought has changed a lot over the past few years about fluid, and mainly also because I look after patients in the ICU, that oftentimes, patients get too much fluid, and we are really struggling to get the fluid off the patients. Of course, if it's trauma and the patient's bleeding, they need red stuff. Or all the other things, sepsis and so forth, obviously we need to get clear fluids. So that's in summary. Thank you very much for everyone. Thank you for inviting me to talk to you. There's my email, and Lauren's also got my email. So if there are any questions or anything like that, please email me or post it. And I will just make the slides available to everyone that would like to have a look at the slides. Kamlan, so I see you've got a question.
Yeah, hi. Thanks, Nellis. Really good talk. So, I mean, those are really good, and the thing in the EC is very useful. One thing that I did find very interesting as well when we went to cardiology, which we don't really spend much time on, is they look at obstructive lesions as well. So they've got this entire sort of ICU protocol where when they obviously care more for the heart than anything else, but looking at the sort of the inflow, the outflow, so whether you've got sort of a SAM lesion or how you figure out that it's aortic stenosis that's giving the problem, where your pressures, diastolic stuff, and they've got quite a nice flow for that. I think the one thing that's useful for us is picking up those, there's quite a few cases, so especially up the SAM, like inotropic induced SAM. So where people would just go, your blood pressure is not getting better, it's actually getting worse. You increase your inotropes because you think that inotropes equal blood pressure. But if you took the time and you look at the heart, you'll actually find sometimes that the heart is underfilled, and because of that inotropic sort of stimulus, that was one thing that came across from cardiology, which I felt that we didn't really get from our other stuff. So I think that's just maybe one thing I might comment on. But yeah, thanks a lot.
Yeah, that's a good point. I think we've got to understand also that it's a dynamic process, and what looks like something in hour 1 versus hour 6 and 10, and the next day is completely different. And I think this is where ultrasound is so useful to have a repeated look and see what you think is going on. And I think, I think from an EC point of view, once you diagnose something like obstructive lesion and so forth, I think, you're probably just going to ask for more advice and more information, because I think at that point, that patient will be referred to cardiology. And unfortunately, people got different ways of doing things. So I remember when I was working at Edendale, also when the cardiologists come in, everyone's just on furosemide and dobutamine, and then you got the anesthetists that think a different way. So oftentimes, it's it's not always, no one really knows always what the right thing is to do. But I think the main thing that I find is that you got to do something and see what happens with the patient. Does this work or does it not work? And I think that's quite important to reevaluate your patient.
Yeah, I think, especially with that IVC, like, we get a lot of stick sometimes from the internal med guys or whatever saying, you're looking at the IVC, it's not this and that. And I think the trouble there comes in, and I think you mentioned it as well, with dichotomizing the numbers. So saying that, above 7 is this, below 7, and rather than that repeated dynamic fluid assessment, do something, see what happens. Same with the CVP. Paul Merrick's paper was sort of a benchmark, but it does underappreciate the sort of continued value of measuring the dynamic changes and that kind of thing.
Yeah.
Anyway, thanks a lot.
I think the danger with us is that we're in a hurry, and when we get a sick patient, we're usually working with a few streams of thought. So we got this patient with his ankle, then I've got the sick guy in resus, and then I've got this kid that's vomiting. And so when we do make an assessment, we oftentimes skip parts. So you just do a quick look at the heart, but you don't look at the rest, or you do a half EFAST. And I think this is where we do ourselves a disservice when we refer the patients. That you must do a proper assessment, especially when you refer these type of patients. Say, I've looked at the heart, I've looked at the IVC. This patient, I think it's unlikely that it's a PE. I've looked, I've done a Doppler to look for clots and all those things. Put it together, rather than just being fixated on a thing. I think So I think that's quite important.
And then just as the last question, have you ever done any of these? So I know the guys looking at the passive leg raise or looking to see if that produces any change in firstly the IVC, and then I've also seen that people want to do a straight leg raise and look to see if the VTI changes by a certain percentage. Now, obviously, some patients can't, like your polytrauma patient, you're not going to go and lift their legs and stuff. But I mean, do you do that in the EC? Do you find that it gives you any more utility above just IVC and looking at the LV function?
Yeah, so I must be honest, I don't do it in the EC. I think for one, I think what COVID has done, it has brought new monitors for us. And so what I tend to do in terms of the passive leg raise is the arterial line, and you look at your pulse pressure variation or your systolic pressure variation. And that's probably the best measure, I must say, at the moment that we've got. Because it's not as invasive, as you don't need a fancy machine. You just need a monitor that can actually just work that out. So that's really what I do. And the monitors that we have now will give you the percentage change or the pulse pressure variation. So I mainly use that. I have to say, I think it's quite troublesome, although it sounds interesting to do the 5-chamber, but practically, it's quite difficult with a sick patient to come back, have exactly the same view and do that, and ask someone to lift the legs while you're looking at the heart. So I think in practice, hopefully going forward, we'll have good monitors where we can put arterial line and do that for the sick patients. Obviously, we can't do this for a lot of our patients, but that's practically what I do at the moment. But it's just because I've got the luxury of a good monitor that can do that. But unfortunately, in the EC, we don't have these monitors, so we're waiting for COVID to cool down, and then we'll move the monitors into EC and start the EC ICU.
Nice.
So anyone else that's got a question or?
Yeah, I think Nelis, Emily asked something similar. Are you happy with the answer that Nelis gave as a follow-on to Cameron's question, Emily?
Yes, I am. Thank you.
Yeah, I think, Nelis, there's a lot of discussion around the value of the passive leg raise. And by and large, I don't know that every EC is equipped to monitor these kinds of patients with an arterial waveform. But in the absence of that, what do you think about passive leg raise?
So I think a passive leg raise is a great thing. I think you're better off doing that than giving a fluid bolus that you can't give back. So I think, even if you just do the carotid VTI, I mean, I think, the apical 5-chamber view is sometimes problematic. And I think if you do a carotid VTI, you've got nothing else, you've got your ultrasound machine, and you do a passive leg raise, and you do the carotid VTI, I think that's probably the easiest thing to do. And that coupled also with what happens with the blood pressure, what happens with the pulse. But I think a passive leg raise is hugely underappreciated in the EC. I mean, we often do it in ICU, but it's something that really is useful. And, to be able to make that assessment without giving fluid, I mean, that's gold. And rather do that and see and ask the question, does my patient really need this fluid? And as I said in the talk, my biggest struggle is getting the fluid off the patient, not getting it into the patient. I mean, it's different when it's trauma, oftentimes, but, once the fluid's given, you can't take it back. And I think probably the first 250 mils, 500 mils probably isn't that problematic, but once you go over that, and you're not understanding what pathology is, then you oftentimes run into problems on day 2, day 3, day 4, day 5 in the ICU stay.
Sure. Yeah, I agree with you. There's one question from Tumi. Tumi, is your mic working? Do you want to ask your question, or would you prefer for me to read it out for you? Maybe you can have a look in the chats. You have access to the chat, hey?
Oh gosh, where
can see
now? Let's get it. No, it says it's only available to team members. I'm not part of the team, it looks like.
Oh, that's so rude. I thought I had added you as a team member.
Rude.
Sorry.
Don't worry.
I think it's because you're not part.
I'm a visitor.
Okay. Okay, I take from Tumi's non-response that maybe her mic isn't working. So her question is assessing the VTI with the 5-chamber view better in evaluating fluid response in intubated patients versus using the IVC?
Sure, that's a difficult question. My personal bias is that the VTI would be better. I think just to look at the IVC has got a lot of other things that you've got to keep in mind. What is the actual right atrial pressure? What settings have you got on the ventilator? Have you got a high PEEP, low PEEP? What are your tidal volumes? And I think those type of assessments become very problematic if you look at the IVC in a ventilated patient. The original work with all the IVC collapsibility was done in spontaneously breathing patients mostly, and this is where all the numbers come from. So once you apply that to a ventilated patient, I'm not sure what, of the accuracy of that once you apply that. So my personal bias is the 5-chamber VTI is going to be much more helpful because that tells you what the system is doing from the right-hand side to the left-hand side and how the left ventricle is responding to what you've done. So my feeling is, I have to say, I'm not the biggest fan of the IVC because I've just had so many instances where it gives me an answer that I'm not sure how to interpret. So personally, I think if you can do a VTI, I would do that. And I think most of the cardiac monitors, actually focus on the left-hand side. And but having said that, I don't think you can do it in isolation. I think have a look at the IVC, see what it says, because if it's completely collapsing, that does have and it's flat, that does have an influence on what you see and what your VTI does on the other side. So again, it's seeing the patient as a whole and not trying to fix on just one single number. I hope that makes sense.
Yeah, brilliant. Thank you. Any other questions from the group? Maybe just while everybody's kind of pondering on their questions, Nellis, there's a lot, you emphasize the value of the provider being proficient in their ultrasound technique. And other than kind of practicing and getting more familiar with it in their clinical units, is there anything else that they can do to try and kind of upskill themselves or become a little bit more confident with their scanning?
Yeah, so I'm an ultrasound trainer, and I think the one thing that I find that people do is that they want to get their logbook signed off, but they don't spend enough time with someone that's actually been doing it for a long time, and really look at technique. Is this, is it that? And I think that's quite a, I'm not sure if it's like that in the metro also, but people want to get their 10 scans and their 10 triple A's and so forth, but actually they need to have that trainer next to them. Look at their technique, what do you think of this and that? And I think that's probably the most useful thing, is that you can stand with someone that's got experience, that's been doing this for years, and just say, listen, I'm struggling with this view. This is what I get. What do you think? How to interpret it? So I think that's probably the best advice I can give. If you have a trainer there, just grab them when you do an ultrasound. Even if you think, oh, this is just trauma, this is just another EFAST. It's not. There are subtle things that you will pick up. And I've spent a lot of time with our MOs, and then they've done a quick EFAST. Oh yeah, I just want to get it signed. But then I go back and I say, listen, did you look at that? Did you see that? Did you look at the spleen? There's so much more than just this level 1. And I think, level 1, hopefully in the future, the medical students will be level 1 trained once they get to their 6th year. I mean, it's ridiculous. And then, level 1 is not something to aspire to. That should be that should be basic. So you've got to move beyond that. And I think there's so many resources out there. So it does have value in doing courses. I mean, not that I get any money from it, but Sonography 123 has got excellent resources, although it does cost money. On YouTube, you can also get a lot of information. So I think that would be my advice. If you've got a trainer, just grab them and just see what they're doing and learn from them. And I think this is how we're supposed to learn in medicine, is to have a trainer next to you and help you and learn from someone. And then, of course, try and do courses to get the background information.
Yeah, I mean, I think that's so helpful. And actually, possibly it would be something to think about in the future, whereby, the registrars all come through level 1 ultrasound and they're all level 1 ultrasound accredited. But we're clearly seeing that from the basis of this discussion and in their clinical practice, that their ultrasound technique goes far beyond level 1, and this is not at all covered in level 1. So perhaps something to think about, whether we can create like a skill session where there's like a real time, one day when we can all gather again.
Well, we've got Teams.
Yeah, we do have Teams, but how do you teach somebody how to scan through a video? Some things, just like with Dave's ventilator talk, how do you teach somebody how to ventilate or set up a ventilator machine through Teams? There are some things where there's just no substitute. You really want to be with the experts and standing next to them and monitoring and visualizing what they're doing.
Yeah, and I think a lot of the problems with a lot of these skills days or courses is that you've got normal people that you're ultrasounding, and you're not actually seeing the pathology. You need to actually be in the hospital where you're seeing, look, what does pulmonary hypertension look like? What does diastolic dysfunction look like? What does, so I think that's one of the problems, is that we don't oftentimes on a teaching environment have abnormal patients. We mainly got normal patients, but to find these patients is problematic. But this is where, if you've got a trainer where you are, just grab them and spend time with them.
Yeah, perfect. Just in the background, we have some comments from Joe, who was part of AMS, that there are ultrasound mannequins. So definitely something for us to look through and to think about in the future when we set up our ultrasound sessions and our skill sessions and that kind of thing. Camlin, you have another question? Do you want to ask your question?
Yeah, no, it's a quick one. I thought I'd just put it in the chat though. Nellis, the story of the IVC. Do you find that you use different measurements? Because I know some people say spontaneously breathing on a vent via an ET tube is different to spontaneously breathing in room air, but they would prefer to use, sort of using spontaneously breathing parameters on the IVC on a patient that's ventilated. So in essence, they could take a mechanically ventilated patient, switch them to a spontaneously breathing mode if that would allow, and then do measurements rather than keeping them on mechanical and using distensibility.
Yeah, so Kamran, it depends what pressures you have in the thorax. So spontaneous breathing patient isn't necessarily what you think it is. I mean, if you've got a spontaneous breathing patient with a pressure support of 5 and a PEEP of 5, yeah, okay, that's spontaneous breathing. But if you've got a pressure support of 12 or 15, that's completely different kettle of fish. They're just triggering the ventilator. So I don't think just switching to a spontaneous mode is the answer. The question is, what pressures do you have intrathoracic? And again, this is where I won't just look at the IVC in isolation. I'll look at the heart, see what the heart is doing, see what the right atrial pressure is, and what the RV is doing, and look at the IVC. So yeah, I think the fact that you switch them over isn't what it's about. It's what pressures you are generating intrathoracically. And of course, if a patient is doing most of the work themselves, it's completely different to you paralyzing the patient and pushing the air in. So context again is important.
And then lastly, are you using B lines at all? I know there's some school of thought that say guys are scanning the chest first, seeing if there's no B lines. Then if you were unsure for any other reason and you gave them enough fluid and you would scan again, and once they developed 1 or 2 B lines, you would stop, because then you're assuming that they're putting fluid into them.
Yeah, so I don't, because I feel personally, once you get to B lines, you've given too much fluid. You should stop way before that. And I think, once that fluid's given, I mean, it just says exactly it. There's interstitial edema already. So that extravascular lung water, if you remember that curve that I had up with the Paul Marey curve, you've already gone into the extravascular lung water area where there's too much fluid on board. So I don't use it personally, and I think you shouldn't be getting to that stage where you're seeing B lines. So that's just my biased opinion. And I think also, look, it depends what's wrong with the patient. If you've got a pneumonia, and I mean PJP is a classic example. They always got B lines. I don't know what to do about that. And also with the COVID patients, they've got a different pathology that I don't know how to interpret the B lines for those patients. So I think it really depends what the underlying condition is again.
Yeah, thanks. I think that helps a lot.
Yeah, Nellis, maybe, it's not strictly a fluid-related question, but actually, there's been a lot of discussion around the value of lung ultrasound in COVID. Maybe you can share some of your thoughts around that, because COVID's not going anywhere for a fair amount of time for us, and the literature is only going to become more robust around what kinds of protocols should we use, what is the value of it, at what point in the assessment, at the beginning, in the middle, at the end, in ICU, in the EC. Maybe you can kind of share some of your initial thoughts and sentiments around that.
So the short answer is I didn't use it in COVID. I think from a diagnostic point of view, you need X-ray. I think my head got a little bit, spinning around, because it looked like everyone's got this ground glassing, because I've been looking at so many X-rays during this COVID time, because I look at COVID X-rays for a whole week, and then I don't, and then so I think from a diagnostic point of view, whether you have B lines or not, and what the pleura looks like, I didn't find it particularly helpful. And also, once you've got B lines, because there is interstitial infiltration, I don't know how to interpret when I give fluid. So to be honest, I didn't use it. The only stuff I used it for, is to look for other stuff. So if there's a pleural effusion, or I'm looking for a pneumothorax, because oftentimes these patients, they've been really difficult. I mean, I usually have dealt with them, of course, when they come in, but also 3 or 4, 5 days, 15 days down the line, and then all of a sudden they crash. And oh gosh, is this a pneumothorax? Is this a PE? Is this a MI? Why did they crash? So to be honest, I think the lung ultrasound I didn't find particularly helpful, and I'm not sure it's going to be helpful in the future either.
Yeah, Okay, great. So jury's still out.
Yeah.
And we have to be careful, you know, we have to be careful about adopting new practices when they aren't purely evidence-based. There is a lot of value for ultrasound, but in this particular area, it's just not validated.
Yeah, definitely. Look, I think the ultrasound has been very useful. I think from these questions, you know, has my patient now developed a PE because I know they're at risk, or did they develop an MI and a DVT? I mean, we picked up quite a lot of DVTs, so it's been very useful. But from the pure lung ultrasound point of view, I didn't find it particularly helpful in terms of my fluid management or management in general. It was just excluding some pathology. Is this a pneumothorax? You know, is this PE or something else?
Yeah, great. Thanks, Nelis. I'm gonna just check to see that we don't have any other questions. Guys, again, I really encourage you to ask your questions now. Obviously, Nelis has been really kind enough to share his details. So if you have any questions for him following on from this, welcome to drop him an email. But this is a really good time to kind of really unpack the wealth of knowledge and experience that he has. Any tips, last minute tips, closing tips or pearls for us? Nelis?
I think from a registrar point of view, I'd maybe just say this. I mean, I've spent a lot of time in the UK, and you know, I've had a lot of people that come, you know, through the years that complained about their training, and I'm sure your training's great. But I think the most I've learned in my registrar time is what not to do. So I've looked at other people and said, I don't want to be like that, or I don't want to do it like that. So even though you might be in an environment where you don't necessarily have all the input that you need, you can always learn something. If you're not learning something, it's because you haven't looked far enough. There's always something to learn, even in an environment where you feel it's chaotic or you're not getting any input. So that'd be just my advice. It doesn't matter where you are. It doesn't matter if you don't have a EM specialist around you to guide you. There's always stuff to learn. So that'd be my top tip. That's for free.
Yeah, I love it. I think that that's great. And wise words, wise words. So yeah, I think we've just scratched the surface of what you have to share with us. For those of you looking forward to our future sessions, Nelis and I have been kind of chatting about a range of different topics, not just critical care, actually, not just ultrasound related, but like a range. So Nelis is like a man of many talents and knowledge. So we look forward to welcoming you back to teaching in the next couple of weeks to months, Nelis. Thank you very much for your time. We really appreciate it.
Thank you, Lauren. I appreciate you giving me opportunity to share some thoughts, and good luck to all of you.
Yeah, great.